we typically look at reams and reams of data, whether we are talking about EHR data or claims data, and then we mash it up with a whole bunch of other external data sources. And typically what this allows us to do is to spot lots of standards of care type patterns through the data. So think, hundreds of millions of patient records across 5, 10, 15, in some data sets all the way back to 30 years. You start to be able to spot certain disease progression type patterns, and as well as what sort of interventions were offered and what may have helped and what maybe didn't work so well for some of those patients. And what this has allowed us to do is to build algorithms that deal, I think, with some of the problems I heard both the physicians that went ahead of me allude to. So one of the sets of algorithms, we actually have it in production, and it's been working in about 14 out of 50 states for Medicare patients, helps case managers and clinical teams at hospitals make the best determination as to where this particular patient on an N equals 1 basis must be discharged to for them to have the most optimal outcomes possible. And obviously, the definition of optimal outcomes, ultimately, for somebody like me, I sit behind a computer and I look at numbers and patterns all day long, but this is delivered not directly to the patient, but obviously to the caregivers, because they bring in the clinical expertise to be able to smell test it and say, hey, in my experience, is this patient likely to have success with this? So think about it as something that takes all of this data and takes all of this tribal knowledge that people would otherwise have to text or phone each other, talk about it and figure out, and basically hands it to someone who is clinically very capable and experienced and says, this is what the algorithm believes is the most optimal path of care. For example, 73-year-old gentleman with COPD getting discharged from a hospital in New Jersey. Must he be sent to a skilled nursing facility, or should he be sent home with some home health nurse visiting him for a certain amount of time, or is he going to be okay just going off home on his own? So if you were to think about it, there's going to be a whole host of clinical factors, there's going to be a whole host of social determinants to consider, some demographics to consider, so on and so forth, like even little data points like, does this person live by themselves? If they needed some very specific care, are they capable of handling it? And then on the social side, maybe this person's been at the hospital for 2 weeks, and by the time they go home, we send them off with a whole bunch of medical care instructions, so on and so forth. Do they have food in the fridge to take their medicine with?